Dorothy McPhee has a life-threatening medical problem, an artery that could burst at any time.
The normal way of doing this operation is generally through the abdomen, a long vertical incision.
Leslie is a young girl with a serious spinal deformity.
The patient is a Jehovah's Witness, and in a procedure of this magnitude, it is unavoidable that some blood loss will occur.
Both patients need surgery. Yet both patients have religious beliefs that preclude their accepting a blood transfusion. Medical science is now providing doctors with alternative strategies to treat successfully patients who, for various reasons, avoid blood transfusions. These new strategies may soon benefit all patients. At the dawn of the 21st century, society is becoming increasingly diverse. People everywhere are being exposed to different languages, customs, cultures, and religious beliefs. Adapting to these differences is a challenge to all strata of human society. It is a singular challenge for the medical community.
We're living in a pluralistic society, and the doctor has one set of values, but he or she will meet patients who have their own values and their own position about certain issues.
There's a lot of different cultures out there, and they have entities specific to their own cultures that we as healthcare workers need to understand.
I think the duty of physician is not simply to preserve life, but the first and foremost duty of physician is to respect the patient.
In the past, the medical profession found it difficult at times to respect the healthcare needs of one religious group in particular, Jehovah's Witnesses. This was because of their avoidance of blood transfusions.
That was the easiest decision, because there was under no circumstances would I accept blood.
One thing I heard, he says blood transfusion, and immediately I said, no, no.
I couldn't live with myself if I turned my back on my beliefs and my God, and I wasn't going to accept a blood transfusion.
Their abstaining from blood transfusions was often misunderstood by the public.
There was certainly a time in years back where Jehovah's Witnesses were looked at by physicians and especially surgeons in a negative way.
I think before I had ever met a Jehovah's Witness, I had a certain mindset that they were maybe a religious fanatic type person.
Part of it, I'm sure, is prejudice about a religious sect which the physician or the judge or the lawyer, about which they may know next to nothing.
A lot of people nowadays have heard of dangers or diseases that might be contracted from blood and blood transfusions. But frankly, for Jehovah's Witnesses, central to their avoiding blood transfusions is because the Bible highlights the preciousness of blood.
It's a very clear statement, by the way. It isn't something that takes a lot of theological study to determine or work out. It says very plainly in the Christian scriptures, abstain from blood.
From the point of view of someone who's not a believer, this seems an irrational act.
For some people, it seems to be anti-medicine. It seems to be somehow putting the patient in jeopardy.
I think some of us, myself included, was under the impression that maybe Jehovah's Witnesses didn't want the best medical treatment, that they were sort of against medical care.
There's no question it mattered to me whether she lived or died. I brought her to the hospital in the first place to help her recover.
I didn't want to just die, and I don't think anybody wants that to happen.
It's not some sort of a suicide pact that they want to enter into with you. They want to live, they want to have good health care, and I think that you can work with them.
I realized they wanted the best medical care, but they just wanted it without blood.
I think the effort has to be made to remove the perception that Jehovah's Witnesses are somehow in a category by themselves.
Clearly you can point to many religions. They all have one issue or another which you may or may not agree, but that's not the issue.
That this is a religious precept. This is not illogical stubbornness. This is a religious belief. And just as I respect the religious beliefs of many other religions, I think I have to respect that.
All patients, as a general rule, have the right to receive treatment or to refuse to receive that treatment after they've had full, open, and candid discussion with the treating physician.
I believe the basic element of patient's right is the right of self-determination. That is the right of any patient to decide what shall be done with his or her own body.
Patient rights notwithstanding, some have claimed that declining what they consider life-saving medical treatment is irrational.
I think it's wrong to equate a refusal of a treatment with suicide, which is a conscious choice to end one's life.
There is always a legitimate question about a patient's competence, but just the mere refusal of blood in itself is not any kind of such indication.
I don't believe that refusal of treatment is irresponsible or irrational. I think that just because one person chooses to not take this pill or that fluid or this kind of solution is their own personal choices.
We have patients who say they don't want to be on a mechanical ventilator, they don't want a breathing tube.
It's an everyday event for a patient who has malignancy, a cancer, to refuse some treatment or other. They don't want to have chemotherapy, they don't want to have radical surgery. So the idea that patients refuse treatment is something that I work with, don't take as a personal insult.
These facts are often obscured by news stories claiming that someone died because he refused a blood transfusion.
To say that one has died because of refusal of blood, I think, is a very general, misleading statement.
That's an oversimplification of the tragic event.
It's rarely, if ever, the case that a patient refused a blood transfusion and therefore died.
People die because of either a medical disease or a consequence of trauma or surgery where there's been complications.
I can tell you, I have done over 200 Jehovah's Witness patients. I have never lost a patient because I could not give the patient blood.
Why then does blood transfusion remain the standard treatment for serious blood loss?
I think that physicians have been brought up with the idea that blood is the gift of life and that inherently blood is good for you.
The refusal to accept a blood transfusion bothers and concerns many physicians because they're worried that without the transfusion, the well-being of the patient is jeopardized.
To appreciate fully why physicians feel this way, one needs to understand a little about blood and why transfusions are given. Blood circulates through the body by means of an amazingly intricate system of conduits called veins and arteries. Arteries carry oxygenated blood away from the heart eventually branching into tiny vessels called capillaries. These deliver the oxygen-rich red blood cells to every part of the body. Nutrients and oxygen are exchanged for carbon dioxide and other wastes at the cellular level. Veins then transport the oxygen-depleted blood back to the heart, which pumps it to the lungs. There, the carbon dioxide is exchanged for oxygen, and the cycle begins anew. This cycle is absolutely essential to life.
If there's no blood to bring the oxygen to the cells die, the body dies.
When someone suffers severe blood loss, doctors have two urgent priorities.
The most critical immediate need is to stop the bleeding.
Everything takes backseat to stopping the bleeding.
And number two is to restore the volume within your system.
What can happen when a patient loses too much blood volume?
Then you don't deliver blood to the brain or to other organs, and a person can die.
And what you need to do is restore volume, restore perfusion, and restore oxygenation.
A way of correcting that decrease in blood volume is by giving other fluids intravenously. This can be done using any one of a number of fluid types and doesn't necessarily require blood.
Increasing numbers of patients are opting to avoid blood transfusions for personal reasons.
If you've ever had a conversation with a patient the night before surgery and you were to ask them if they had a preference, would they prefer to avoid a blood transfusion, the answer is always yes.
I would say that today at least 80% of the patients would strongly favor not to have blood transfusions.
Blood transfusion, traditionally considered a normal adjunct to surgery, presently is considered something that has to be avoided.
I mean, there are real risks as far as transfusions are concerned.
There are concerns about bloodborne pathogens and certainly the concern about AIDS.
It's a biological product. It can have diseases, etc. We screen for most of them, but there are some there that we just don't know about.
We've certainly seen some horrendous new diseases in the form of HIV come along that probably didn't exist in the past. Whether the next disease will come along in 10 weeks, in 10 years, or 100 years, nobody can say.
We have hepatitis C, hepatitis B that are transmitted, and the social costs of that are very high.
There are transfusion reactions that occur. They're very rare, but they can be potentially dangerous or even life-threatening.
We can mix the blood up and cause catastrophe. Patients have died and do die from getting the wrong blood.
It is interesting to realize now in the late 90s or early 2000 that the blood transfusion to a certain extent does not do what we always use blood transfusion for.
We have become persuaded over the years that many of the bad things that happen to patients after surgery are in fact not bad luck, are not lack of surgical skill, but are in fact the complications of transfusion.
These concerns have spurred the development of a wide range of alternative strategies, treatments that are acceptable to many of Jehovah's Witnesses and others who also choose to avoid blood transfusions. Alternative strategies can be grouped around 4 organizing principles.
That involves anesthetic factors, it involves the use of certain substances, and it certainly involves also the surgical technique.
The most important technique to control bleeding is to avoid bleeding. That with less bleeding during surgery, the result at the end is better and the outcome is more likely to be smooth.
Careful surgery means preventing blood loss. Age is no factor. We have operated on newborns. We have operated on people in their 90s.
A surgeon who operates without losing large amount of blood is almost invariably a good and careful surgeon. One who loses large amounts of blood is most often the reverse.
A variety of instruments are now available to help surgeons minimize bleeding.
There are strategies for intraoperatively using electrocautery instead of scalpels.
If there's some bleeding persisting, there are coagulation techniques, best of which is at the moment argon beam coagulation.
There are non-invasive tools that enable the surgeon to see inside the body, minimizing surgical incisions.
You can use drugs, a topical application of different products that will help prevent blood loss.
We have now several methods available, like the fibrin glue.
Fibrin glue, made from blood fractions, stimulates coagulation upon contact.
The fibrin tissue adhesive is certainly very, very useful because it does not harm the tissue.
In a Jehovah's Witness, where blood loss is so critical, I think that you have to be very extremely meticulous not to lose even a drop of blood.
There are new technologies of hemodilution and reinfusion that make the operation easier and which are acceptable to people who have a religious precept against blood transfusions.
The principles of hemodilution in terms of reduction of blood loss are really quite simple.
Basically, we do a closed circuit on the patient. We draw off blood from the patient, keep it in contact with the patient, and substitute it with fluids.
That results in a diluted blood, and therefore the patient loses only diluted blood rather than native or concentrated blood.
When the patient bleeds intraoperatively, the red cell loss is less.
It would be like taking a quart of milk and adding water, so you have 3 gallons of it now, but the original quart is still in there. But if you were to spill it into something, it would be a lot of water and a fraction of the milk. And then at the end, you get rid of the water, and then you're back to where you started.
And we use that routinely in this institution, especially for those patients who have anticipated a significant blood loss.
I think that's probably nowadays, besides not just for Jehovah's Witnesses, a pretty good standard of care for large volume loss surgery.
If we do lose blood, this is the kind of case where we'll use a cell saver. It will suction up any blood that's lost. We wash it, we clean it, we process it, we filter it, and then we'll give it back to you.
Cell salvage is a very important technique because when you use cell salvage, the blood lost by the surgeon is not lost for the patient.
In any trauma patient with a significant blood loss, I would always prepare the cell saver system.
A key element in stimulating the body's ability to replenish its own blood supply is a hormone called erythropoietin.
Erythropoietin is a natural substance. It is formed in the kidneys, other organs as well, but primarily the kidney, to help our bone marrows form the red blood cells that are going to carry our oxygen.
Blood cell production takes place primarily in the sternum, the ribs, the vertebrae, and the pelvis. Recombinant erythropoietin boosts the body's natural production of red blood cells.
So if I know the patient's going to be in the hospital a long time, I may start them on some recombinant erythropoietin so that they can start building up their own blood stores.
This can be a very cost-effective strategy to reduce the utilization of allogeneic blood transfusion.
One of the most exciting things about this whole field in transfusion alternatives is that the majority of things that we talk about are within the reach of physicians and hospitals around the world.
There are now available techniques in almost every subspecialty of surgery and medicine that allow bloodless treatment.
Alternatives, like any other therapy, are not necessarily free from risk.
So a patient, a witness patient in particular, may want to become informed about the benefits and the risks that are associated with any particular treatment.
They should be a prudent consumer.
How effective are these alternative strategies in helping doctors treat patients who do not want blood transfusions? Leslie Lax had just begun elementary school when it became apparent that she had a degenerating spinal deformity. Doctors diagnosed Leslie's condition as a severe form of scoliosis.
Scoliosis is a curvature of the spine, so we have to correct it as much as the spine flexibility allows us.
After a brace failed to correct her condition, doctors recommended an extensive surgical procedure.
We use essentially a series of hooks and metal rods made out of stainless steel that are implanted in the patient's back and used to essentially distract the spine and achieve alignment.
The Lax wanted the surgery performed without a blood transfusion, so they found a surgical team that had experience using bloodless techniques. Before the surgery, Leslie's doctors boosted her blood through the use of iron and recombinant erythropoietin.
So it was essential that we do the surgery without excessive blood loss. The way that we were able to achieve this is using two techniques. Basically, one of them is what's called the cell saver. The other technique we used is called hemodilution. It is safer in that it is the patient's own blood and it has remained in continuous circulation with the patient, so there's no chance for contamination or blood-transmitted diseases.
The surgery was a success, and no blood transfusion was administered. Within days, Leslie was up and walking.
She's so happy. She can be able to stand. She always say, "Mommy, I'm almost tall as you now."
Although Leslie will have to wear a brace for a while, doctors are confident she will lead a normal life.
I would like to skate and skateboard, maybe learn how to snowboard and stuff like that.
Sometimes alternative strategies involve new surgical techniques to reduce blood loss in patients that don't want a transfusion. 75-year-old Dorothy McPhee suffered an abdominal aortic aneurysm, a life-threatening condition that traditionally requires extensive surgery.
The normal way of doing this operation is generally through the abdomen, a long vertical incision from the lower chest down to the pubic area, having to work around and behind the entire intestinal tract, hospitalization ranging at best days, 4 or 5 days, to an average of a week or even more, presuming there are no operative complications.
Since Dorothy is one of Jehovah's Witnesses, her physicians used a surgical technique that minimizes bleeding.
What we did today is called endovascular aortic surgery. Specifically, endovascular meaning we're working within the artery. Through that artery, we place our catheters, our wires, all the instruments that we steer right up into where the aneurysm is. And then we can visualize the aneurysm by doing fluoroscopy, X-ray technology.
Dorothy's surgeons inserted a wire mesh called a stent and were thus able to repair her aorta without a large surgical incision that would have caused a lot of bleeding.
Small incision in the groin, all the manipulations through that, a virtually pain-free, complication-free post-operative course, home generally 24 hours. So everybody's a winner.
I feel fine. I never would have believed it, but I do.
2 days after her surgery, Dorothy was sent home. She recovered nicely. A growing number of healthcare providers are willing to meet the challenge of treating patients who avoid blood transfusions.
With the development of all those techniques, there's nothing really specific about Jehovah's Witnesses anymore. We know that they don't want blood transfusion, and we have the technology to follow their wish.
The belief that you don't want a blood transfusion should not in any way, that should be a tiny part of the whole medical care environment. That should be acknowledged, be put over to the side, fine. Now's the other 99% of your care.
I guess it could be likened to a patient who is allergic to penicillin. You wouldn't expect the physician to say, well, I'm sorry, I can't treat you because I can't administer penicillin. No. He simply says, we'll give you a medical alternative. We'll give you another antibiotic. And he gets on with treating the patient.
This enlightened approach to patient care has exciting implications for the public at large.
The fact that we couldn't use blood in Jehovah's Witness, we learned how we didn't have to use blood in many, many other situations. So it has actually propelled us in the right direction.
Transfusion alternatives clearly are good medical practice, sound medical practice, safe practice for our patients.
Indeed, it is a standard that should be available to all patients.
What we're talking about here is going to be a moot point, because bloodless medicine and surgery will become, in the next 5 to 10 years, so widespread that it won't be novel anymore.
Jehovah's Witnesses have had the unique privilege, because of their religious position in the matter, of helping doctors to learn better ways to treat patients without subjecting them to the risks of blood transfusions.
What I have seen in my own experience is that they have turned the medical profession around to the point where the gold standard of treatment frequently now is to treat people without blood.
Already, some 100,000 physicians worldwide are making bloodless medicine and surgery available to any patient who does not want a blood transfusion. Many experts agree that in the near future, medicine and surgery without the use of blood transfusions will be the standard of care for all patients.
There are now available techniques in almost every subspecialty of surgery and medicine that allow bloodless treatment, that we are getting away from blood transfusions in general.
As a heart surgeon, it's unusual for the guy not to like blood. You should love blood, but I don't. I'm very proud when my patient comes out of the operating room, has not received any transfusion.
I can see within the next few years us getting to a point where we do not have to even think about giving blood.
In Berlin, Professor Roland Hetzer at the German Heart Institute corrects a ventricular septal defect in a 10-month-old girl. In Jena, Professor Johannes Scheele at Friedrich Schiller University Clinic performs a liver resection.
Roughly 30%, which is left behind.
In London, Peter Earnshaw, a fellow of the Royal College who practices at Guy's and St. Thomas hospitals, performs a total knee replacement. Challenging surgeries, but they share an added dimension. In each of these cases, the team had committed itself to operating without allogeneic blood transfusion. Today, in 150 countries, more than 100,000 physicians have made a similar commitment to bloodless medicine and surgery because they believe transfusion alternative strategies are simple, safe, effective. Many view the pioneering bloodless major cardiovascular surgery of Dr. Denton Cooley in the 1950s as the beginning. He cooperated with patients who are Jehovah's Witnesses and who, while seeking quality medical and surgical treatment, do not accept allogeneic blood transfusion. They observe the biblical injunction, abstain from blood. In 1977, Cooley's team published a report on their 20 years of experience with a consecutive series of 542 bloodless cardiovascular surgeries. The report noted an acceptably low risk. Professor Richard Spence, a pioneer in transfusion alternative strategies.
The lessons we learned in the early stages of bloodless medicine and surgery with the Jehovah's Witness clearly translated over to all of the rest of our patients. So the field now really of blood conservation includes the use of multiple alternatives in a planned way to avoid the need to transfuse a patient with someone else's blood. We have operated on newborns, we have operated on people in their 90s, and we use these same techniques and approaches.
Professor Albert Huch, speaking of efforts in the general patient population.
In the era when the risks of blood transfusion were not realized as they are today, 15% of all women in such a group of at-risk patients received blood. Today this figure is far below 1%, even though we are a center for complicated cases.
We've now reduced our transfusion rate for knee replacements, knee revision, knee replacements, I think of the order of 5 to 8%. Ideally, we'd like to get it down to 0.
Professor Hetzer points to one reason for such efforts.
Today, at least 80% of the patients would strongly favor not to have blood transfusions.
And for legal and ethical reasons, today attention is increasingly being given to respecting the wishes of the patient. Experts also cite their desire to avoid medical risks related to transfusing allogeneic blood.
Any unit that is donated into the blood bank, whether it's an allogeneic unit or a PAD unit, there's always the risk of administrative error and an ABO mismatch and a fatal hemolytic transfusion reaction.
Side effects include not only the transmission of viral diseases that everybody talks about, like HIV or hepatitis B or C, but also new viruses that are prevalent in the donor population. Also, parasitic diseases are more and more transmitted via blood transfusions.
The public health impact of transfusion immunomodulation is very difficult to estimate, and we've estimated that approximately in the United States we can expect that 10 to 50,000 patients a year may be dying from transfusion immunomodulation related causes.
Will existing viruses mutate and produce disease? There's no reason to believe that they won't.
Many see these risks and the resulting costs, but feel that they have no alternatives to allogeneic blood. However, even the benefits of present policies on the use of allogeneic blood come under question in view of a groundbreaking study by Dr. Paul Hébert of Canada. It compared a liberal transfusion policy with a restrictive one in critically ill ICU patients. The results were surprising, particularly the mortality rates.
I talk about the Hébert paper where they showed in more than 800 patients that less transfusion results in an improved outcome.
Other evidence showing the need to review policies on the use of blood comes from two earlier studies. Consider first the Sanguis study, published in 1994. Part of a concerted action of the European Commission's Medical Research Program, the study analyzed transfusion rates in major healthcare centers across Europe. 43 teaching hospitals were prospectively studied as to their routine transfusion rates for 6 common standardized operations. The Sanguis study revealed that different institutions routinely transfused drastically different percentages of patients for the same surgeries, varying from 0% at some institutions to 96% at others on coronary artery bypass graft, and from 0 to 100% on total hip replacement.
The main lesson is the variability of transfusion practice from one center to another for the same specific operation.
In 1998, in Belgium, a follow-up study was published.
So all types of hospitals were included in the Belgium Biomed transfusion study for surgery. And we found exactly the same range of variability.
So we are left with the conclusion that variability implies that a lot of these blood transfusion components are being given unnecessarily.
However, there is a positive note regarding 2 Belgian hospitals that participated in both studies. After the Sanguis study, they changed their transfusion policy.
They had somehow managed to reduce their blood consumption for major surgery like colectomy for cancer by a factor of 5 at least. The hospital stay was shorter, so we have no evidence of increased morbidity nor mortality.
In the light of what has been learned in the last few years, Professor Philippe van der Linden summarizes what many experts have concluded.
In view of the potential for a better patient care and reduced health care cost, blood conservation is not an option, it's a must.
But what is the foundation for an effective transfusion alternative program? Experts agree that it is a team approach.
It truly has to be a cooperative effort, a team effort to the approach. And it has to be tailored to the patient's condition as well as the operative procedure. Some techniques are appropriate for some procedures and some surgeons, and not for others.
The various transfusion alternative techniques used by successful teams can be placed under 3 basic principles or pillars.
Preoperative planning involves to realize that a patient has not enough endogenous red blood cells for a planned operation. And this depends not only on the hematocrit, but also on the estimated blood volume of a given patient, the estimated blood loss that the planned operation is associated with, and also the transfusion threshold that can be considered reasonable or tolerable in this individual patient.
The first pillar can be defined as appropriate tolerance of anemia. This involves reconsidering the standard policy on anemia treatment. Some still use a transfusion trigger of a hematocrit of 30% or a hemoglobin level of 10 grams per deciliter for all patients, thresholds that date back to an article by Adams and Lundy published in 1942.
I am really convinced that there is no place for the magic 10 gram.
Our experience with Jehovah's Witness has shown that, first of all, we don't need the hemoglobin levels we assumed were essential previously.
But there should be no hard or fast rule, or there should be no trigger. You can anesthetize patients for some procedures, depending upon the patient, as low as 2 or 3 grams if necessary.
All experienced physicians stress the importance of maintaining normal volemia via simple volume replacement. With adequate volume, oxygen consumption is maintained over a wide range of hemoglobin levels. According to Professor van der Linden, the 2 main mechanisms responsible for the maintenance of adequate tissue oxygenation are an increase in cardiac output and an increase in tissue oxygen extraction. In the range of hematocrit values illustrated, the amount of oxygen extracted from the red blood cells of a non-anemic person is practically the same as that taken up from fewer red blood cells under acute normal volemic anemia. The first mechanism results from the decreased blood viscosity and sympathetic stimulation. The second mechanism results from a redistribution of blood flow to areas of high metabolic demand and from improved microcirculation.
I am really convinced that a better knowledge of the mechanism allowing the maintenance of adequate tissue oxygenation during acute dermovolemic anemia could decrease the risk of blood transfusion.
What does experience with this principle alone reveal?
I halved our transfusion rate by simply saying, could we lower our triggers from 10 to 8? And just taking a little more control over the decision. That was very easy. That cost nothing.
We do know that we can allow patients to equilibrate to relatively low hemoglobin levels without blood transfusions.
Obviously, it is important to plan ahead, especially if the patient, for religious or other reasons, refuses allogeneic blood. Pre-operative planning requires a careful clinical assessment of the bleeding risks and a thorough laboratory screening, including standard hematological parameters. Based on the patient's condition, this may include other tests, such as a coagulation profile, and tests for conditions contributing to anemia. Next, there is the need to calculate the safety zone or tolerable red blood cell loss for a particular patient throughout perioperative care. Here is how Professor Earnshaw explains his approach using the example of joint replacement.
All you need is height and weight, male or female, initial hemoglobin, hematocrit, and you can immediately work out what their blood volume is. Next, either using your personal data, and anybody who's doing more than a few joint replacements should be able to go back and look what their typical loss is. So you want to know what loss there will be for that particular procedure. And the only other thing you need to know is how much can you tolerate? In other words, how low can you let this patient go?
What if the expected RBC loss is greater than the tolerable?
You can increase the blood loss that is tolerated by the patient by simply lowering the threshold of transfusion trigger, or you can increase the allowable blood loss by increasing the initial hematocrit of the patient and therefore have the patient start or go into the operation with a higher mass of red blood cells.
Several of these proactive techniques can be grouped under the second pillar, optimizing RBC mass.
We can expand the circulating red blood cell mass of the patients before the operation. And this can be achieved with cheap hematinics like iron, folic acid, vitamin B12.
For selected cases, recombinant erythropoietin, or EPO, combined with iron therapy can be used to treat anemia or to raise the pre-surgical hematocrit to within a range of 45 to 50%. EPO is normally started 10 to 21 days prior to surgery. EPO, illustrated by small particles, increases red cell production by affecting the survival, differentiation, and maturation of erythroid cells in the bone marrow. In the late erythroblastic stage, the nuclei are expelled. Finally, the erythrocytes are pushed into the bloodstream. Note the acceleration of red cell production with EPO. Besides the increase in RBC mass, under EPO treatment, usually 1 week is gained. Note the comparatively higher hematocrit rise under EPO therapy, according to one study.
And utilizing erythropoietin, we can increase the circulating hemoglobin by 1 gram deciliter for each week of treatment.
Recombinant human erythropoietin therapy is a tool that has also been shown to be effective as a blood conservation strategy. It's been shown particularly in orthopedic procedures in patients who are anemic. And by that I mean whose initial hemoglobin is less than 13 or hematocrit is less than 39%.
Now we use erythropoietin in very specific cases, like for instance also the children of Jehovah's Witnesses, where we start to administer this medication 4 to 6 weeks before the operation. It's given twice a week with a dosage of 400 units per kilogram.
If you combine the two principles, that is, increasing the preoperative hematocrit and decreasing the threshold for allogeneic blood transfusion, then you can allow an even larger blood loss to occur without the need for allogeneic blood transfusion. Now, this allowable blood loss can be further reduced, certainly, by surgical techniques or by anesthesiological techniques.
Thus, even such complex procedures as spinal surgery and redo open heart surgery are routinely performed with an even wider safety zone afforded by the third pillar of a transfusion alternative protocol, either by minimizing the bleeding or by recovering shed blood. Let's consider several important intraoperative techniques. Patient positioning is a simple, cost-effective technique to reduce bleeding. Local venous pressure changes depending on the field's position relative to the heart, and lower pressure directly correlates with blood saved.
It's important to position the patient properly during orthopedic surgery. In my experience, it makes a big difference in spinal surgery.
With pressure on the abdomen, and thus on the paravertebral veins, blood loss increases. With proper support, avoiding abdominal compression, blood loss decreases. Another option to decrease venous pressure in some surgeries is to use regional instead of general anesthesia, as shown here prior to a cesarean section. A further technique is the maintenance of normothermia, especially during long operations.
So if a patient is cool or cold by 1 or 2 degrees temperature, you are seeing a loss in ability of platelets and coagulation factors to work. So it's essential that we keep the patients normothermic.
Normothermia is extremely important, and therefore our operating theater temperature is 27 degrees in those major procedures, which sometimes is hard for the surgeons, even for the anesthesiologists, but it's very good for the patient.
More directly, the patient's body can be warmed with a thermal suit or blankets. There are even simple machines to warm fluids before infusion. Next, hemodilution.
The principles of hemodilution in terms of reduction of blood loss are really quite simple. If blood is removed from the patient immediately prior to or immediately after induction of anesthesia and replaced with acellular fluids, then when the patient bleeds intraoperatively, the red cell loss is less.
For every 100 mLs of whole blood lost by the patient, in the case of a patient with a hematocrit of 27%, they're going to lose 27 mLs of RBCs rather than the 45 mLs of RBCs they would have lost had we started the case at a hematocrit of 45%.
Additionally, the hemodilution procedure is acceptable to a number of Jehovah's Witnesses.
Hemodilution is certainly cost-effective, but not only that, it is also beneficial for the patient, as it improves blood rheology, as has been shown by many studies.
Another transfusion alternative technique for selected surgeries is induced hypotension to lower mean arterial pressure intraoperatively. Usually a drug is used to decrease systemic vascular resistance. This typically prevents up to 50% of blood loss. Anesthesiologists urge caution when combining hypotension with hemodilution because hypotension can interfere with the normal redistribution of blood flow. A crucial factor that requires skill and patience is meticulous surgical hemostasis and technique.
Take your time and not my blood.
I teach the residents to just gently score the skin and open it, and then use the cautery to get all the blood vessels.
The basic technique for a surgeon to control bleeding is to ligate the vessels. That's true for all the vessels, let's say, down to 1 millimeter in diameter. If there's some bleeding persisting, there are coagulation techniques, best of which is, at the moment, argon beam coagulation. We use it routinely in liver transplantation.
Hemostatic agents can also assist.
There is two types of agents. General agents that could be administered intravenously, such as tranexamic acid or aprotinin. And the surgeons have also the possibility to use topical glues in order to better control the bleeding in the surgical field.
Here, a fibrin glue pad is directly applied to the dissected surface of a liver. This product, containing a blood fraction, is accepted by a number of Jehovah's Witnesses and others. The final intraoperative transfusion alternative is called cell salvage. If intraoperative bleeding becomes heavy, a cell salvage machine, often kept on standby, is able to recover the shed blood. As the blood flows through the device, some machines simply filter out any debris, while other types include the additional step of washing the red cells as they circulate. A cell salvage machine can save up to 50% of the blood that would otherwise be lost. Such devices are acceptable to a number of patients who are Jehovah's Witnesses.
Cell salvage is a very important technique because when you use cell salvage, the blood lost by the surgeon is not lost for the patient. Cell salvage is usually used when you expect the blood loss in the range of 1 liter and more for an adult patient.
Perioperative blood salvage is a very useful technique for blood conservation because it's very easy to organize in the majority of operations. Cardiovascular, orthopedic, gynecological, and so on. So it can be widely applied in surgery.
Some machines allow cell salvage on a small child, expanding the horizons of the technique. Often, simple cell salvage machines are also very valuable in the post-operative setting.
What we tend to do, particularly for knees, where it's often done with a tourniquet and there is no intraoperative loss, we salvage it immediately afterwards. It's very simple and very useful and moderately cheap. Just the stuff that comes out, filter it and give it back. And we've been doing that here now for about 4 years, and we're very pleased with the success rate.
Another important consideration for minimizing blood loss is the use of microsampling for necessary tests. Microsampling is critical in both preoperative and postoperative care of infants and anemic adults. Professor Michael Obladen addresses the challenge presented by premature infants.
It helps teaching the doctor the amount of blood really required and not to take more. Formerly it was, if in doubt, take 0.5 milliliter more. We don't speak about milliliters anymore, we speak about microliters. The whole process of sampling is documented in the baby's chart so that everyone is aware about the cumulative amount of blood withdrawn.
Professor Ernest Moore on microsampling adults.
If you add up the blood samples, it's remarkable how much is taken off in a week of the ICU care. So certainly using microtubule type of analysis, we can markedly reduce the number of cc's of blood lost today for sampling.
Physicians who advocate transfusion alternative strategies are often asked if these same strategies are applicable to trauma or emergency care.
When you're looking at principles in patients who have trauma or massive blood, unanticipated blood loss, is first and foremost, act quickly. The cessation of bleeding, whether surgically or in other means, must be the first principle. The second one is that one can apply these modalities, such as cell salvage, under specific circumstances and recoup the patient's own blood.
The anesthesiological concept are to tolerate a certain degree of relatively low blood pressure and to be a little restrictive in infusing enormous amounts of volume, particularly before a surgical source control has been achieved. That means before the surgical bleedings have been identified and stopped.
Perhaps one of the, I think, greatest advances in conserving blood in trauma has been the concept of so-called damage control surgery. That is, once we open the patient's abdomen or chest and note that the patient is unable to coagulate, that we address the major bleeding vessels, then control the surface with pads and close the patient temporarily, allowing them to be taken to the intensive care unit where their resuscitation is continued, and efforts to reverse those adverse effects on coagulation like hypothermia are specifically addressed.
In trauma management, rewarming is very important because during advanced hypothermia, blood coagulation doesn't function properly and therefore the blood loss is larger.
Professor Moore reviews additional effective steps.
As you move into the intensive care unit in the more complex problems, then I think the use of erythropoietin becomes even more compelling in the trauma patient. In Jehovah's Witness patient, we have no delay in providing both erythropoietin and iron immediately after they arrive in the hospital. We may in fact do preemptive interventional radiologic evaluation of solid organs and embolize arteries that are not currently bleeding actively but are at risk for bleeding later.
This brief overview of strategies is properly viewed as a comprehensive concept.
To say there's a list of transfusion alternatives is correct, but that really does not get to the heart of the issue, and that is that we must use those alternatives in multiple combinations focused on the patient.
Not everyone needs every strategy, the erythropoietin being a very good example of that.
Dr. Todd Rosengart has published 2 major studies on multimodality blood conservation in coronary artery bypass operations performed without allogeneic transfusion.
When we looked at a series of 50 Jehovah's Witness patients and 100 patients in the general population, we found a shorter length of stay and a lower cost using our blood conservation strategy.
Medicine gives every indication of rapid advancement in this new millennium. In the meantime,
I think all physicians should be interested in blood conservation strategies because there's substantial evidence that reductions in morbidity and mortality and reductions in cost can come with these strategies.
The less blood that is transfused in a given surgical program could be used as an index of the quality of that program.
I think that the safest transfusion is the transfusion never given.
And blood conservation is a very simple method which makes things rather smooth, less expensive, and with a better outlook for the patient.
I think there are some very simple, very cheap things you can do which would help the majority of people, and this could be done in the smallest of hospitals.
Transfusion alternatives are safe. This is not just something I use for the Jehovah's Witness patient, for example. I use this for every patient who comes to me. Transfusion alternatives clearly are good medical practice, sound medical practice, safe practice for our patients.
Each year in this new millennium, pressures on healthcare systems mount. The growing number of patients, particularly the elderly, challenges healthcare providers' ability to meet patient needs with available resources. At the same time, legal and ethical voices increasingly advocate that patients be permitted a greater role in choosing their treatment. These developments especially affect one major sector of healthcare.
There's a growing concern on the part of physicians that our approach to blood transfusion needs to be reevaluated.
Today, at least 80% of the patients would strongly favor not to have blood transfusions.
News headlines show this. Both physicians and patients are faced with transfusion complications, supply shortages, and concerns about blood product safety. As just one example, the World Health Organization calculates that around the globe, unsafe transfusion and injection practices cause some 5 million hepatitis C virus infections each year. Increased efforts by national healthcare systems to achieve a safer blood supply have caused the cost of blood to spiral upward.
2 years ago, it cost us about 63 euros per unit of transfused blood. It now costs us 142.
Treating transfusion-related side effects has incurred additional costs.
These costs, which are indirect and delayed, are enormous and clearly would raise the cost of a unit of blood substantially.
The same holds true for compensation totaling billions of euros or dollars that have been paid to recipients of tainted blood and to their surviving families. As society faces these issues, transfusion risks and costs, is there a better approach? Might transfusion alternative healthcare meet patient needs and rights? Professors Earnshaw and Hetzer and countless other clinicians have responded to the requests of patients and of parents of minors. Consider 3 examples of complex surgeries performed without transfusion. Open heart surgery is consistently a major challenge. In Berlin, Professor Roland Hetzer explains why he had to operate on the tiny heart of a 10-month-old baby girl.
This child has a congenital heart defect, which is relatively rare. It means there is a direct communication between the left ventricle and the right atrium, which creates a continuous abnormal flow between the left heart and the right heart.
The defect was corrected with a heart arrest time of only 26 minutes, and the blood flow normalized. No transfusion was given. In fact, there was virtually no blood loss. Another example. Liver surgery usually involves considerable donor transfusion. In Jena, Germany, at the University Clinic, Professor Johannes Scheele here removes the cancerous portion of the liver from an elderly man.
How much was the blood loss today? 250 cc's.
No donor blood was given, and 18 hours later, the patient is chatting with the doctor in the ICU. Now an example of orthopedic surgery. In London, Royal College fellow Peter Earnshaw successfully performs a total knee replacement on an elderly woman, typically a high blood loss operation. All 3 successful operations were accomplished by surgical teams committed to respecting the patient's or parent's preference that donor blood not be given. Were these experimental operations by 3 pioneering surgeons? There are more than 100,000 physicians and surgeons in 150 countries who routinely treat patients without donor transfusion. Some experts feel
every anesthesiologist and surgeon should be interested in blood conservation strategies because it's good patient care.
When physicians who turn to transfusion alternative health care are asked why, they often cite as a major reason respect for their patient's decision. Professor Blumberg, director of a transfusion medicine unit and blood bank.
Well, I think there are a growing number of patients who are interested in being treated with either no transfusion or the minimum amount of transfusion possible, and there are some folks who strictly don't want to be transfused under any circumstances.
Another area motivating physicians and surgeons to change their approach is the growing evidence of inconsistent practices leading to unnecessary transfusions. everyone concerned with improving healthcare or protecting the individual patient should consider some revealing studies on blood use. First, the Sanguis study. As part of a concerted action by the European Commission Medical Research Program, transfusion rates in 43 major teaching hospitals across Europe were analyzed. The ramifications of the Sanguis study are staggering. For the same type of operation, there were enormous variations in the number of units transfused depending on the hospital. In 1998 in Brussels, Professor Ball published a follow-up study.
All types of hospitals were included in the Belgian Biomed transfusion study for surgery, and we found exactly the same range of variability.
So we are left with the conclusion that variability implies that a lot of these blood transfusion components are being given unnecessarily.
A comparison of the two studies revealed another significant fact.
There were two centers which participated both in the Sanguis study and in the Biomed study.
Based on their findings in the Sanguis study,
they had somehow managed to reduce their blood consumption for major surgery. The mortality was the same before and after the changes. The hospital stay was shorter. The new procedures they adopted weren't very difficult to adopt, although they took time and took a considerable educational effort, but they didn't result in increased costs.
Soon after, in Canada, Dr. Hébert did a large-scale study of critically ill patients in intensive care. Professor Spahn evaluates the results.
I talk about the Hébert paper where they showed in more than 800 patients that less transfusion results in an improved outcome.
The obvious conclusion is that unnecessary transfusion translates into unnecessary labor and unnecessary cost. Besides patient demand and over-transfusion, many physicians cite as motivation to implement transfusion alternative healthcare the desire to avoid medical risks.
There's the risk of bacterial contamination in a stored unit of blood.
Bacterial contamination, whether occurring at donation or subsequently from improper storage, can cause infections having fatal consequences. In another arena, despite improved testing, viral infections continue to pose a serious threat. Experts are concerned about what the future holds.
Will existing viruses mutate and produce disease? There's no reason to believe that they won't.
The problem with contamination of transfusions, it always seems to be one step ahead of us.
In addition, blood transfusion induce a immunosuppressive state with the recipient, and that results in increased postoperative infections as well as earlier and more often recurrence of tumors.
We've estimated that approximately in the United States we can expect that 10 to 50,000 patients a year may be dying from transfusion immunomodulation related causes.
Likely, the most surprising and least recognized medical risk is human error. Giving blood of an incompatible type can cause a reaction ranging from mild to fatal. Professor Spence, a director of surgical education, acknowledges.
We can mix the blood up and cause catastrophe. Patients have died and do die from getting the wrong blood.
In fact, reports indicate that human error causes up to 1/2 of all transfusion-triggered deaths. In the light of such realities, patient decision, unnecessary transfusion, medical risks, as well as shrinking blood inventories and soaring blood costs, Professor van der Linden summarizes what many experts have concluded.
In view of the potential for a better patient care and a reduced healthcare cost, blood conservation is not an option. It's a must.
The good news is that safe, practical, and cost-effective therapies already exist.
The best medical care can be delivered without the use of allogeneic blood.
There are some very simple, very cheap things you can do which would help the majority of people, and this could be done in the smallest of hospitals.
Blood conservation is a very simple method which makes things rather smooth, less expensive, and with a better outlook for the patient.
The transfusion alternative techniques used by these surgical teams can be grouped within one of three basic principles, or pillars. The first is tolerance of anemia. Racing through the arteries, red cells carry life-sustaining oxygen to all parts of the body. The anemic patient has a low number of red cells in relation to his blood volume. If a person suffers extensive blood loss during surgery or as the result of an accident, the body can tolerate anemia to a considerable degree. Professor Moore, an acknowledged pioneer in trauma surgery.
Studies have shown physiologically that the human being can tolerate much lower hemoglobin levels than previously assumed safe.
The medical community is starting to realize that tolerance of a significant anemia is doable for patients.
However, anemia is tolerable only when the body has sufficient circulatory volume to continue to function.
We also know that with that anemia, we can compensate with volume, because volume is the critical component here to maintaining blood pressure.
With low-cost blood volume expanders being available, current medical opinion increasingly abandons the arbitrary rule proposed back in 1942, that a hemoglobin level of 10 was the transfusion trigger, or the lowest acceptable figure before administering a transfusion. Thus, Professor Earnshaw notes his first step in implementing a transfusion alternative program.
I halved our transfusion rate by simply saying, could we lower our triggers from 10 to 8? And just taking a little more control over the decision. That was very easy. That cost nothing.
Simply implementing the first pillar would cut out millions of transfusions and save billions of euros or dollars annually. The second important principle in transfusion alternative strategies involves stimulating red cell production in the patient's body. This is important for an anemic patient before surgery, and it can speed recovery after extensive blood loss. Studies directed by Professor of Obstetrics Albert Huch have shown
sufficient iron supplementation can already normalize the blood count to a large extent and at relatively little expense.
In selected cases, the genetically engineered drug erythropoietin, commonly called EPO, can be used. Professor Mercuriali, a director of transfusion services, explains.
Stimulated by the administration of erythropoietin, there is an acceleration of production of new red blood cells.
The third principle, or pillar, is to minimize blood loss.
The most important technique to control bleeding is to avoid bleeding.
Meticulous surgery is practical and cost-effective. A variety of tools can be used to assist. For example, electrocautery devices enable surgeons to cut rapidly and to seal blood vessels immediately. There are also modern drugs that can reduce bleeding. Some are applied directly to the bleeding area. Here, a fibrin glue pad is used to stop blood from oozing out of a dissected liver. Professor Baron notes about the cost-effectiveness of such agents.
The decrease in intraoperative bleeding and the decrease in the use of blood products compensates for the cost of the drug.
Another effective technique to minimize loss in instances of heavy bleeding is to salvage the patient's own blood. Recovery of as much as 50% of the blood otherwise lost has become a reality. This technique also meets the ethical needs of many who absolutely refuse donor transfusions. For instance, some of Jehovah's Witnesses have allowed cell salvage to be used. There are even such machines designed for small children.
Cell salvage is a very important technique because when you use cell salvage, the blood lost by the surgeon is not lost for the patient.
Many other beneficial strategies are available. all assist in avoiding the risks and societal costs of millions of transfusions. To illustrate the impact of properly combined techniques, consider the task faced by the medical team of 4-year-old Luana in Modena, Italy. She was born with a serious heart defect. Her team, headed by Professor Marcelletti, chief of cardiovascular surgery, had to perform a series of complex operations. As requested by Luana's parents, the first operation was successfully done without donor blood. Once again, for the second procedure, there were both skilled personnel and the appropriate equipment, including a cell salvage machine. The meticulous surgery, utilizing electrocautery, took 2 hours, and Luana lost only 100 milliliters of blood. Her parents were delighted, and the medical team was pleased with the outcome.
We have performed the operation without the use of blood transfusion, as we try to perform with all of our children.
I think all these little babies deserved not to be transfused and not to take the risk of blood transfusion.
Further proof of the effectiveness of heart surgery without transfusion is provided by Dr. Rosengart.
When we looked at a series of 50 Jehovah's Witnesses patients and 100 patients in the general population, we found a shorter length of stay and a lower cost using our blood conservation strategy.
While many clinicians would hold that some situations absolutely require blood, what is the view of those experienced in the use of transfusion alternatives in life-threatening emergencies? First, an anesthesiologist's perspective.
The cessation of bleeding, whether surgically or in other means, must be the first principle. It's important to act quickly and to keep in mind that modalities are still available even in a trauma situation.
Next, a surgeon's perspective.
In any trauma patient with a significant blood loss, I would always prepare the cell saver system.
In one of the busiest trauma centers in the United States, Professor Cohn, Chief of Trauma and Surgical Critical Care, notes about patients declining donor blood.
We see more than 3,000 patients a year here that are Jehovah's Witnesses, and we do about 250 to 275 major operations on them each year. And what we have seen in our population is no increased length of stay, no increased mortality. In fact, it appears to be somewhat decreased.
On the basis of such experience, many physicians conclude that, overall, transfusion alternative health care is cost-effective.
Well, one of the beauties of transfusion alternatives is that the most effective alternatives are generally the cheapest.
There's no doubt that blood is a costly product. We've been able to reduce our blood transfusion bill for the liver transplant program here by 70% since we started adopting new techniques, and that equates to hundreds of thousands of pounds in a year. And it's far more than the costs of the drugs and the other therapies we use and the mechanical methods we use for reducing blood loss.
It takes more dedication than technical means. Similar results can be achieved without the use of costly machinery.
And transfusion alternative healthcare has a benefit beyond saving money and meeting patients' physical needs. There is an ethical benefit. This care honors the patient's freedom of choice to accept or reject a certain treatment.
One of the primary principles of good medical care is being concerned about what the patient wants.
Professor Harding, who teaches ethics to medical and law students.
Today one would link that ethical duty, not to do harm, to seek the best possible outcome for one's patient, with another duty which is to respect the autonomy of the patient, to respect the patient's own views and decisions.
At Glasgow University, Professor of Law and Ethics in Medicine, Sheila McLean summarizes.
Doctors have virtually an absolute obligation, both legally and ethically, to respect the patient's choice.
Concerning the advancing legal view generally designated patient rights, Professor Guillot, founder of the Health Law Institute at Neuchâtel University.
I believe the basic element of patient's right is the right of self-determination. That is, the right of any patient to decide what shall be done with his or her own body.
Patients have a right to be told that there are alternatives, and more than that there are alternatives. What are the respective risks and benefits expected to be associated with those?
Concerning the evolution of patient rights, Professor Weissauer explains.
Earlier, the doctor determined how to proceed and thereby shouldered the entire responsibility. In the course of time, the relationship has changed more and more into a partnership, doctor and patient meeting each other with full equal rights.
Recognizing patient rights accords with the UN's Universal Declaration of Human Rights. In fact, these legal issues have become so important that in 1997 the Council of Europe formulated the Convention on Human Rights and Biomedicine. Article 5 proclaims, "An intervention may only be carried out after the person concerned has given free and informed consent to it."
The doctrine of informed choice says that it is up to the patient to accept or to refuse any kind of medical act, for instance, a blood transfusion.
Addressing a sensitive issue, Article 6 states, "The opinion of the minor shall be taken into consideration as an increasingly determining factor in proportion to his or her age and degree of maturity."
There's no doubt that minors, in a legal sense, can and very often are able as adolescents to take decisions about their own treatment and their own health.
How does freedom of choice for patients and parents work out in practical terms?
Well, if the physician cannot think of finding a way of accommodating patients' desire about alternatives to blood transfusion, he should try to refer the patient to one of his colleagues or to another institution or healthcare facility where this alternative is really practiced.
But what about emergencies, where the victim may not be able to speak, to convey personal conviction?
It's now recognized that people have the right to indicate treatment choices in advance. And this takes the form of a written document where the patient shows that they have considered certain situations and they've taken a clear position about a treatment choice.
In an emergency, one would always also search for an advance directive or a durable power of attorney, for instance, in the wallet of the patient.
Respecting patient rights also has healthcare benefits.
There is empirical evidence that patients who feel engaged in their treatment are likely to get better quicker.
Consider, for example, a case at St. Richard's Hospital in Chichester in southern England.
Well, Mrs. Whittington had arthritis of her hip, which was so advanced that she required a total hip replacement. She is a Jehovah's Witness and therefore declined to have a blood transfusion.
Well, I do believe that God's word is against taking blood, and we should appreciate that God's word is the truth. Mr. Patel was quite happy to do it without blood.
It is the doctor's responsibility to listen to patients' demands, listen to what they have to say, and to give them an informed choice of alternatives.
In frank dialogue between physician and patient, the question of whether she would accept cell salvage arose.
When I knew more about the machine, and it was explained to me, and said I would accept having the machine.
The relationship between the patients and the medical staff is excellent here. We have a very open culture and a good learning environment.
What was the outcome of this cooperative approach?
The strategies that we used intraoperatively during Mrs. Whittington's operation were meticulous hemostasis, salvage of blood using a cell saver system, as well as using a cemented hip replacement. She tells me that she is delighted with the operation in terms of the pain relief.
As Earth's population continues to grow and age, their medical needs will be a greater challenge to healthcare structures, many of which are already struggling. In this regard, transfusion alternative healthcare offers a promising direction.
A well-adapted blood conservation program means a decrease in the total cost for the patient, but also a decreased cost for the society.
While all medical interventions involve risks, transfusion alternative healthcare uniquely meets both patient needs and rights.
I can foresee that in the future, patients will almost expect that any surgery which is necessary is carried out without blood transfusion.
Patient empowerment is important, not only to better respect autonomy, but to promote good medical treatment.
The various steps to reduce the need of blood transfusion nowadays are very well established, well tested, and they are certainly safe.
This is universal, can be practiced in any institution in any part of the world.
Blood conservation is a safe, effective, and progressive medicine.
This is the best way of treating patients and clearly should be a standard of care.